Now I would like to request Dr. Priya Tathe to present her e-poster.
Good morning everyone. I am presenting a pseudotumor case. So inflammatory pseudotumor is a non-neoplastic lesion characterized by fibrosis and inflammation. It can be locally aggressive and resemble malignancy and extranodal lymphoma. It has been described in nearly every anatomical site throughout the body, but the involvement of skull base is associated with more aggressive behavior. So I am reporting a case of 40-year-old female patient who came with complaints of left-sided severe headache, recurring diplopia, left-sided ear fullness with intermittent reduced hearing. She was treated multiple times with steroids, antibiotics and painkillers which reduced her symptoms temporarily. When she came to us, we did DNA which showed well circumscribed mask, left nasopharynx which bleeds on touch, otoscopy revealed left middle ear effusion. She had left lateral rectus palsy. So MRI was done which showed an hyperintense lesion arising from left fossa of Rosenmuller extending to foramen ovale and eustachian tube. There was carotid encasement and effacement of cavernous sinus. So biopsy was done which came out to be benign lymphoid hyperplasia. But her symptoms persisted even after giving treatment with IV steroids. So after 2 months, we again did a revision MRI, which showed increase in the size of the mass. And to rule out dual pathology, PET CT was done, which showed hypergenously enhancing soft tissue lesion, which was suggestive of adenoid cystic carcinoma. So the patient was posted for partial excision of the skull base mass by transmaxillary transpterygoid approach, and deep tissue biopsy was taken from foramen ovale by transnasal extended endoscopic method and sent for frozen section, which came to be which showed no malignancy. So after 3 months of follow-up, we did DNA which showed healthy nasal cavity, and PET scan showed there was no metabolically active disease. So the most common differential diagnosis of mass in nasopharynx is nasopharyngeal carcinoma. So to differentiate between inflammatory pseudotumor and nasopharyngeal carcinoma, on MRI, pseudotumor is seen as an hypointense as compared to parenchyma, as well as pseudotumor is submucosal. Also, the involvement of internal carotid artery encasement and resulting narrowing is seen in pseudotumor and not in carcinoma. And the extensive patchy meningeal thickening and enhancement is a feature of pseudotumor, not of carcinoma. The diagnosis of pseudotumor is difficult in that it cannot be made definitively by current radiological techniques, and FNAC and biopsy are often non-specific. To conclude, this case highlights the relevance of entailing inflammatory pseudotumor in differential diagnosis of infiltrative nasopharyngeal and skull base lesions. Surgery is generally required for diagnosis, but awareness of this lesion prevents unnecessary radical surgery. And another important sign to be aware of this is the absence of pathological cervical lymphadenopathies despite aggressive lesion in nasopharynx and the skull base. Thank you.
What is the follow-up and outcome?
Yes, sir. After 3 months of follow-up, we did DNA which showed healthy nasal cavity.
No, not clinical. Patient symptoms along with radiology. You have shown the radiological pictures.
The symptoms has also relieved, sir. She doesn't have any recurrence till now.
3 months follow-up.
3 months follow-up.
Okay.
Yes.
Any literature supporting your poster?
Yes, sir. In literature also, it is the same, sir. The diagnosis is very difficult. We have to operate many a times, but the thing is the awareness prevents the radical surgery, which we generally go for carcinoma. Yes.
Immunohistochemistry done in all your histopathology specimens?
No, sir. Immunohistochemistry was not done for this case.
Thank you.
Thank you, sir.
I request Dr. Shashin Kritika sir to present Priya. Rahul Shenai. I request Dr. Rahul Shenai to present his e-poster, nasopharyngeal mucormycosis.